Hello, I'm Sarah Day, Policy and Research Manager at the HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. Today on the episode we have two very special guests, Lee Outhwaite, Director of Finance and Contracting at Chesterfield Royal Hospital NHS Foundation Trust, and Dr. Sanjay Agrawal, Consultant in Respiratory Medicine and Critical Care at University Hospitals Leicester NHS Trust. Alongside their busy jobs, they are both also HFMA trustees, so we asked them to share their insights about the importance of collaborative work between clinicians and finance professionals. This is a topic that they're both very passionate about, and you'll hear them speak about the need for everyday leadership and how colleagues shouldn't ask for permission to work more collaboratively. So without further ado, let's hear from Lee Outhwaite and Sanjay Agrawal.
Well, welcome. We're doing a podcast now, my colleague and I, so we'll introduce ourselves and then we'll crack on, and we're having a little bit of a talk about how clinicians and finance staff can work together. So my name's Lee Outhwaite, I'm the Director of Finance from Chesterfield Royal Hospital. I'm also the STP Finance Lead, I'm a HFMA trustee, and I also serve on SIPFA Council, so I do a few bits and bobs. And my far more eminent colleague to my right, but you don't know that because we're on the audio, is...
So my name is Sanjay Agrawal. I'm a consultant in respiratory medicine and critical care in Leicester, and I'm also a trustee at the HFMA. And I have to say, this conversation is one that Lee and I would often have, and so we're just recording it on this occasion.
Yes, absolutely. So this is well-rehearsed ground, but hopefully we might be able to bring together a little bit of insight. But we're going to circle through the nature and way in which clinicians and finance staff need to understand the business we serve, if we like that. There's a bit of what does collaborative working look like, about how do finance staff, clinicians come together, how do you really reap the benefits of sort of quality improvement projects through the finance agenda, how we might lose patient level information, put outcomes a bit more centre stage, and really get into value-based and population health conversations. But if we start first, Sanjay, your kind of experience of working with oddities like myself.
So as a clinician, it's been fantastic, this sort of journey I've been on around understanding finance. And actually, I have to say, Lee, again, I probably bored you with this before, but I first started to try and understand finance when I ran a healthcare sort of management leadership course for doctors in training. And our deputy director of finance came along and talked about finance. And when I thumbed through all the evaluations, he got the best evaluation. I thought, oh, why is that then? I mean, he was a nice chap and all of that. He was very engaging. But I realised it's because doctors know nothing about finance. So literally everything he said was a revelation to all of these people. And thinking about it, we get no training in our postgraduate training or undergraduate training to do with NHS finance. Yet, as doctors, we make a lot of decisions that, of course, utilise healthcare finance. So it's a little bit strange in that regard. So anyway, so the long story is that I then went on to do a whole bunch of financial workshops for clinicians, and they were lapped up. It was like pushing against an open door. They wanted to know more, and that was like 10 years ago. And I think we've made some strides into engaging clinicians and teaching them, but there's a long way to go. There's 1 million clinical staff, and not all of them, finance isn't going to be for all of them, but actually a lot of them want some knowledge because they want to apply it to pathways, because they, obviously like all of us, want better patient care.
And I see that as it's a key part of that NHS finance practitioner role, about how can you explain to clinical staff how they're incurring costs and how they're getting value out of their interventions. And I really think in that engagement you are really pushing on an open door. And for me, that there's an epiphany that sometimes happens around senior clinical leaders in sort of management, where they kind of go, actually, I can self-actualise as a clinician, not just by serving the patient in front of me, but really thinking through how do we deal with that wider queue of patients and the population that we serve. And every time I have this conversation with clinical staff, they're intrinsically motivated by trying to do the right thing. And it's quite easy to galvanise around, if the treatment and care was for your mum and if it was your money, what would you do? And just getting to that common language, I think, with clinical staff is relatively easy. I think getting finance staff to the point of they really understand what's motivating doctors around their tripartite mission, both around treatment and care, but education and training, and then the clinical research they do, and really understanding that and meeting it is what we should be about in terms of what we're trying to do with finance staff. So I think there's loads of ground in there, and there's loads of good work going on. I just think how you can get into that common narrative and dialogue between finance and clinical staff is entirely possible. And when that works well, we're not the miserable grey suited souls just saying no to stuff. There's a far more facilitative conversation about, if it was your money, it was your money. How would we kind of go about doing this then? And I think everybody's intrinsically motivated to do the right thing if we can just empower them a bit.
Well, actually, something that you said there is I actually think that finance teams understand population. So most clinicians will think about the person, the patient in front of them, and that's where, unless you work for public health, but most clinicians will just really focus in on that one or two, the patients in their clinic that day or on the ward at the moment. Whereas finance teams, by definition, will think about everything. They'll think about all the patients you're going to see that month, that year, and how that's all going to work. So actually, I think putting the two together actually works really well. But they've got to not. I think the key thing is that obviously that's going to be collaborative and it's not going to be threatening. And so one of the things, so value is a key area that I think everybody can agree on. And I once did this training session with there's 100, 150 doctors in training, and I asked them, what do you think the definition of value is? How would you define value? Now, in my head, I've got the really sort of simple Porter equation, which I've always loved because I can actually understand it as, quality divided by cost, I suppose multiplied by timeliness and sustainability. But I quite like that definition. But a lot of people are really struggling to understand it. And another way of thinking about value is, of course, waste. And nobody likes waste, and that can be a bit more resonant. I think waste is the reciprocal of value. But anyway, so it doesn't really matter how you sort of get them to think about value, as long as they think about it. And once people start thinking about value and the whole context, then they move away from that individual patient, and then they can hopefully take on board, the wider areas of knowledge they need to apply.
Absolutely, and I think the next big step for us about how we do get that right finance to clinical engagement across the NHS absolutely is reliant on how do you really dig into that sort of whole notion of value-based healthcare and what we're doing around population health. So we're about to publish shortly a sort of roundtable output looking at value-based healthcare and really getting into what conversation are we having there. And it was quite interesting when we're talking about value-based healthcare, what's the scope of our definition? So what I mean by that is I think increasingly the challenge for us in the NHS is if you believe what our public health colleagues say about your health and well-being is actually 20% determined by what the NHS does, and there's 80% determined about sense of place, sense of purpose, economics, housing. I think increasingly the challenge for us over the next 10 years is going to be into, is our licence to continue doing the things in the 20%, which we've historically done, is that licence generated by the NHS more getting on the pitch of health and well-being? Because if we don't do some of that, our hospital sector will be a warehouse full of people with socially determined disease, as opposed to the people we might prefer to have in it, which is the people who are having the sort of latest cutting edge technology stuff done with them to extend and enhance their lives. And through that roundtable, we were just having the discussion around, we're kind of reasonable at sort of productivity, and we have been for ages, about outputs over costs. We're slightly less good about efficiency, but not bad about outcomes over costs, but really getting into that technical value space about where are we under or over intervening, what's the limit to effective care, and can we have an honest conversation around that with amongst ourselves and with patients before we get into that much broader canvas of sense of place and sense of purpose, and is that somewhere where the NHS staff could be? And I think finance have got an enormous role, as candidly some of our clinical staff get more and more subspecialised and all of our patients get more and more comorbid, to try and be the honest broker in, well, what's the sensible limit to intervention here? And if it was your mum and it was your money, what would you do? So I think that value-based approach beyond what we've historically conceived of that of, I think that's all where it's at, which leads us into that whole population health agenda about, well, what are we about then? And I think, without being over dramatic, I think we've got a bit of an existential crisis as the NHS about, well, how do we get into that then? How do we partner differently with communities, local government colleagues to go, actually, if you're miserable and socially isolated, the best thing to do with you might not be to truck you into hospital, see a cardiologist. There might be a different looking intervention that might be the right way to go.
So I completely agree with that, and actually I was at a conference just today, in fact, about, and we were talking about integrated care and the social determinants of health. And in fact, Professor Sir Michael Marmot was in fact there speaking. If you're cold and lonely, well, actually, that's going to have a bigger impact on your health than probably anything else. I think as a finance function across commissioning and across public health and across the NHS, we need a better way of if you like, paying for the costs of delivering treatments. Now, I'm not just talking about medical treatments, I'm talking about a more holistic treatment. So, be it social prescribing and or other measures that might help people stay well rather than just treating them when they become very sick. It might also include, funding better screening programs. It might be all the stuff to do with public health, actually, in part, the prevention. So in the past, prevention has largely been seen as an isolated thing that public health bodies do, but actually prevention is key. I think we spend something like 4% of our national health and social care budget on public health, and actually the reality is we need to be investing more in that. But in the meantime, I think the paradigm of primary and secondary care needs to somehow be dismantled, and we need a better way of financing individual patient care, with prevention and the social determinants of health being a much bigger focus than they currently are.
So I think as we kind of cast forward, and we're all behoved to think long term, and we've done another 5-year more or less strategic plan, that this whole how you do that clinician to financial engagement, about how do you get out of this somewhat difficult, demand's going in one direction, funding's going up a bit more than once it did, but probably not enough to meet that. Therefore, what are the quality improvement initiatives that we wheel out and put centre stage that don't just deliver improved care but save money? I'd be quite interested in exploring, Sanjay, our sort of shared experience of, I once had a very sage associate director in one of my specialties when I first arrived as a director of finance, who said to me, look, Lee, what you've got to bear in mind when you're in the director of finance role is, if you try and describe any of our improvement work in money, it completely alienates people. So stop doing it. And he was absolutely right. So if we're describing how do we reduce visits that we might not need to hospital, how do we try and ensure we've got minimal pre-operative and post-operative length of stay, how do we really ensure that patients are only alighting in the hospital sector when they really need to? I think there's a real challenge on the finance side when we aggregate everything up and go, oh crikey, there's another 15% of the budget we've got to save against next year. I think it's really interesting how as a finance profession we get a bit more slick at, we're not just going to explain, oh crikey, there's another 15% of the budget we need to save next year, but what are the things that we all agree are sensible to do that might just result in saving 15% of the budget next year? I think different organisations do that differentially well, but I think that's the real challenge. But I think people can prick up their ears on the clinical side when they go, crikey, there's a lot of money to save. But it's only really made real for me when we get into how do we improve the quality of the care that we give? How, as an intensivist, do we make sure we've got the right patients in intensive care? How do we make sure we only got people coming into the hospital when they need to? I think the description of that in those non-financial terms, it's far more likely to get into a sort of more meaningful dialogue than, Sanjay, can't I just take 10% of your bed base out and can you
it's
give up with those old folk that you keep treating in IT.
Well, I'll give you an example. So, for instance, we know that emergency admissions, oncology admissions are really bad. They're bad for patients. They're bad for the health system, and so we are trying to. I work in an area with lung cancer, and there's something called the optimal lung cancer pathway. And really, that's all about diagnosing people much more quickly and getting them started on treatment much more quickly. Now, the knock-on benefit of that, of course, is that you get fewer later stage presentations and you get fewer people presenting in extremis to hospitals and then having a lot more money and unnecessary investigations thrown at them. So really, it's, and if you describe the pathway of earlier diagnosis, earlier treatment, that's your hook. If you say, I want to take out 20% of cost, that's just going to disengage people. So we should always be describing things in terms of patient pathways, stuff that we know causes harm. We know that hospitalising a patient causes harm. It deconditions them. People with dementia get more disorientated. Yeah, you can pick up hospital event. The list goes on and on and on. So describing it in that way makes so much more sense. And I think that finance business partners are going to be a key component of doing that. So I personally, if I had a blank sheet of paper, I'd sort of make everybody a finance business partner and let a robot do all the invoices and whatever else. And also, I think we need to train clinical finance business partners. So, probably for every one finance person, there's 30 clinicians, and you can't have millions of finance trained finance business partners. So I think we need to start training many more clinicians to be the equivalent of a finance business partner, where they can talk to peers, they understand it enough about how money moves through the system to then improve pathways for patients and focusing on the quality and the value. And I think that can be done today. In fact, at my hospital, we're starting to do that. We've not called them clinical finance business partners, but we're starting to do that. And I would like to see that actually everywhere.
And I think as we're striving for patient level information, people are scurrying around doing goodly work on patient level costing. I think there's a real interesting thing about what information can you bring to clinicians' attention so that they can really identify what is the warranted versus the unwarranted clinical variation. And as skilled and as groovy as we are as finance staff, and as much as we like being outnumbered 1 to 30 by our clinical colleagues because we like a challenge, I think there is something absolutely in the space of how can we help present information to clinical staff where they can ensure, in a non-punitive way, the healthcare we're delivering has got absolutely warranted clinical variation in, because lamentably medicine, there isn't a recipe for it. But where can we really root out and help our clinical staff at a clinical leadership level to go, actually we'd far rather be associated with a hospital or a healthcare system that's really running in a sort of best practice type sense, and we're helping clinical staff if they're not managing to get to that. And I think when clinical staff aren't managing to get to that, it's not through a lack of ambition, but it's perhaps systems and processes and other things, or just information. So I think there's something about, actually I think clinical staff going, well, the thing that would make me deliver a more value-driven healthcare system is if I really had access to this sort of information or this sort of advice. Yeah. And I think if we get a more informed set of clinical staff saying, look, we all want to be associated with good value healthcare, how do we partner to that? I think it's a critical question for us.
Yeah, and actually tools like PLICS can be invaluable. So again, there's a few clinicians where I've sort of talked about PLICS, and it's just been liberating. They didn't know that PLICS existed and that this data was being collected and how it could be used to help them unpick pathways and to understand that unwarranted variation. So it's great to see things like the EVO program from HFMA or in fact GIRFT or the NHS White Care stuff, all around unwarranted variation, and then clinicians being able to use that to understand why they may be a good or a bad outlier and what can be done, and what other lessons can be then applied to other areas in which they work. And actually, just data in general is really useful. I think one more thing that I'm sure Lee, you might know about, and others, is that clinicians are incredibly competitive. So if you give them data about their own performance, the next thing they're going to do is look at the data that of their mate and other people, because they intrinsically want to improve actually. And so if we can provide good quality data that they've maybe co-produced and worked on too, through PLICS, for instance, or through GIRFT or something else, then they're going to get engaged and use that data effectively to get better value.
Absolutely. So I think despite the kind of ever-present challenge of NHS management about dealing with the patient load today, that whole how do we reach out and provide a bit of time for that engagement with our clinical colleagues, really having that value-based discussion and going, well, what are the outcomes that we'd all collectively be after, and how do we measure that? And can we get into that far broader conversation about health and well-being? I think it's a really interesting time for the NHS at the moment, but hopefully not in a Chinese curse type way, about the historic, I've described this back in Derbyshire, is kind of our historic state of working on sort of one side of a canyon with this kind of purchaser-provider splits, range of bilateral contract agreements, this historic separation between primary and secondary care, little focus to some extent of the NHS on broader determinants of disease and working more holistically on health and well-being. If that's historically where we've been at, I think this is really exciting, but other side of the canyon, about moving in the direction of a sort of funding allocation to integrated care partnerships, then providers, demand and supply managed, risk managed within those integrated care partnerships, and an ability to integrate more closely with primary secondary care, put a bit more centre stage how you work with local government and the third sector. So it's just the moment where perhaps some of the historic conversations we've had, particularly in secondary care, about what we've found important financially to keep the show on the road for the provider sector, there's a different level of conversation we now need across healthcare systems that I genuinely think, sort of 27, 28 years into my NHS finance career, is genuinely exciting. Ain't going to be a picnic, all challenging stuff, but probably a far more interesting way of working, about looking at populations and geographies and partnership working, and just a bit more license to do that wouldn't do us any harm.
Yeah, I agree, and I think probably the last thing that I wanted to say is that we need everyday leadership. So we don't need permission. I don't think what we shouldn't do right now is ask permission. Yeah, I think there's never saying never seek permission, always seek forgiveness. So I think we should be doing this now. I don't think we need somebody at the top to say, okay, in a few years this is the direction of travel, think about this. I think that a lot of what we've talked about today could be happening today and should be happening today across all of our organisations, and actually some of the integrated care with primary and secondary care, thinking about the social determinants of health, working with our local government colleagues. There's no reason why we can't get on and do this at a local level now. We don't need a new plan. We should just do this.
Absolutely. So there you go. There's a few thoughts perhaps on how clinicians and finance staff can work together for the benefits of patients, which huge part of the HFMA's mission, and hopefully there's been elements of this talk that somebody might have found useful. So that's Lee Outhwaite, Director of Finance at Chesterfield, and
Sanjay Agrawal, Consultant in Respiratory and Critical Care in Leicester.
Signing off. Cheerio. Good luck.
That was Lee Outhwaite and Sanjay Agrawal. Thanks to both of them for sharing a really engaging conversation. Lee mentioned a recent roundtable that the HFMA hosted with the Healthcare Costing for Value Institute. The roundtable focused on measuring outcomes and addressed the importance of clinical collaboration. You can read more about the discussion in the February issue of Healthcare Finance. Dr. Sally Lewis, who chaired the roundtable, also wrote a blog about collecting outcome data. She highlights that outcome data is not primarily about comparing performance, but about understanding patient needs, enhancing communication, and supporting new models of care. You can read the full blog on our website at www.hfma.org.uk. At the HFMA, we strongly believe in the power of collaboration between clinical and finance staff, and we work hard to support this. Our qualifications are a great tool to support clinicians to understand more about finance and work more closely with finance colleagues, equipping them with the knowledge to collaborate better and influence decision making. Thank you very much for listening to this episode of HFMA Talk. I hope you've enjoyed it. Remember to subscribe to the podcast and follow us on social media to keep abreast of the latest HFMA news. If you'd like to get in touch with any suggestions for future episodes of this podcast, then please email us at policy@hfma.org.uk.